Welcome to the RedMed podcast, Rescue, Expedition and Disaster Medicine, where we provide a platform for healthcare professionals working in or aspiring to join rescue, expedition and disaster response teams. A platform to share information, advice and opportunities and connect like-minded RedMed individuals in our community. Good afternoon everyone and welcome to episode 21 of the RedMed podcast, Rescue, Expedition and Disaster Medicine. As usual, I'm joined by our SOS Crew Chief, Chris Sharp. Good afternoon, sir.
Good afternoon.
And as usual, the podcast is supported by SOS Coffee, which we've been drinking all day, prior to and after a critical care flight and all during the planning of this podcast. So, yes, dehydrated, overdose on caffeine. We're also sponsored by Life Systems Medical, high-quality British-made medical equipment, which we've recently used on our wilderness first aid courses in Ecuador for the Red Cross and the firefighters down there. Excellent equipment, mountain safety gear, personal gear, survival gear, and pre-made first aid kits for every eventuality. Well, it's nice to see you again, Chris. We've been apart for a while.
It's been busy.
Been extremely busy, arranging courses and training in most of the Central and South American countries. I've just got back from the EMS World Conference in Ecuador, which was fantastic. Meeting old friends and new friends, expo of new equipment. We got together with the International Paramedic registry to overview competencies for the new registration standards. Met with the NAMT committee and formed the first Latin America regional committee for the NAMT and courses. I was lucky enough to be at the launch of the Orange Book, basic pre-hospital training, first aid for EMTs. Most of the Latin American reviewers, editors and authors were there, so it was a great event and a fantastic publication, certainly for our EMT courses. Then we went to the PHTLS 9th edition instructor update. Some exciting changes. I think in our EMS, in our ambulance service, we're using most of those changes already, from TXA, vacuum mattresses, pre-hospital ultrasound, but not just changes to the core content in PHTLS, but changes to the methodology, the way it's delivered, the way the students interact, the whole flipped classroom approach, different assessment standards. So it's quite an exciting future. It's definitely had a facelift, the course, and it'll be more interactive and more versatile, I think, for students in the future. What else do we do? I was involved in a pre-conference course teaching wilderness first aid up in Quito to the bomberos, the firefighters and the Red Cross. That was fantastic. Ended up covered in fake blood, mud and sand, and couldn't have been better. Great day on the hill. And then we got to launch, we gave a speech at the EMS conference on RedMed, what it is and are we prepared, which I think hit home with a lot of people, particularly given the market. There was a lot of people from Ecuador, a lot of people from Chile and Puerto Rico who've lived through disasters and been part of rescue teams and disaster response teams. And they really got it. You know, some of the teams were very professional. Some of them were street, urban EMS providers that found themselves in the middle of a rescue or disaster and put their hands up and wholeheartedly admitted they weren't prepared. They didn't know how to navigate, they didn't know how to treat water, they didn't know about high-angle rescue, didn't know how to adapt protocols to a specific environment. So the intro of the RedMed really opened people's eyes as to the routes they can go down or what pre-training they need to be competent and current to deploy with teams like that. While we were there, lucky enough to link up with Dr. Gustavo Flores from ECC Trainings in Puerto Rico, who also flies a flight physician for Riva. Elkin Fuentes, part of the TCCC affiliate faculty. And then Dave Page, as most of you know, from EMS World, the magazine, NAMT, and the International Paramedic Registry. So great to catch up with you guys, and we came back to Guatemala full of motivation to inject all of these new initiatives and the information into the company. Yeah, it's been a busy week. Luckily enough, we also bumped into the Flightbridge ED guys down there. There was Eric and Ashley Bauer, Mike and Dave, who also contribute to the podcasts. Great to meet you guys. Thanks very much, and hope you enjoy the SOS coffee. I heard great things about the course, the FPC preparation course in Ecuador, the first of its kind in South America, and I'm sure it'll do really well in Latin America. It's the guys are buzzing, and it's definitely needed in this region. So well done, guys, and hopefully I'll come up and see you in Alabama on the next course.
With more coffee.
Yeah, absolutely. Oh, what else have we got? I think we've talked about the 9th edition PHTLS, the whole approach. So going back a couple of weeks...
Before your week away.
Before my week away, we're at another expo, the Heli Expo in Atlanta, where you were lucky enough to receive the Safety Award, a Salute to Excellence Award for Safety. I say lucky. It's all in the preparation, the diligence and your experience. But we also met some great guys from Priority 1 Air Rescue there who convinced us to upgrade our equipment. We bought the new patient extraction or extrication platform, the PEP hoistable litter. We've tried it, we've tested it, we love it. It's absolutely bomb-proof, versatile. We'll give you a write-up, guys, but brilliant. There's photographs on our social media already of us trying it with a helicopter the other week. But as with everything, and as I'm sat next to the safest man in the world, we believed you. We did believe you, but we tried and tested it after a coffee in our little bat cave. We looked at it, we picked it apart, we tested it, we wrote the procedure, we dry tested it again, and then we took it on the mountain and we did an exercise combined with the Heli SS crew, the Red Med crew, and the local fire service rescue team. And we did a patient extraction off the hill with the PEP and with the hoist or the strop. Human external cargo, it probably saved us a 6-hour walk in the humid jungle coming down from a volcano. I think it was a 6-minute flight to get the patient off the hill. Anyway, going back a step, in the dry testing phase, I was hanging off the rafters in our ambulance car park testing it.
With me laughing?
With you laughing. I'm always the one that's suspended while you look out the helicopter and laugh. While I was suspended, I was in what I thought was a comfortable harness, but very, very quickly I felt uncomfortable. And very, very quickly my toes started to go numb and I could feel my legs swelling up, which kind of brought me around to the next topic, which is suspension syndrome. We thought we'd talk a little bit about that. It's been formerly known as suspension trauma, harness hang syndrome, orthostatic intolerance. Doesn't necessarily need to involve trauma, so therefore these days most of the literature is referring to it as suspension syndrome. As we know with normal physiology in the body, blood is returned to the heart via the venous system through a combination of vascular contractions with support from the valves preventing backflow in the veins in the lower extremities. That's how the blood should return to give a sufficient preload, and then you get a good ejection fraction and prevent shock. So who can be affected and how can they be affected by suspension syndrome? Who can be affected? Anybody working at height, anyone in the rescue, expedition, disaster medicine, military or industrial sectors that are suspended vertically in a harness for a prolonged period of time could become affected. From rescue techs to climbers to tree surgeons, parachutists, hang glider pilots, cavers, industrial personnel working at height. It could affect a whole bunch of us, not necessarily just in the wilderness.
For us, the short hauling, like the missing tourist that I did a couple of weeks ago, I was short hauled from sea level to 7,500, 8,000 feet. It was a 35-minute flight each way in a harness, and there's ways around us getting this, but it is a long time to be hanging in a harness.
Yeah.
So those who come on the red course, especially Guatemala, who do the short haul, you will may be affected by this, which as a rescue team you never need rescuing. It's something you've got to prepare for, train for, and understand and prevent getting it in the first place. because where I was short haul to was a little rocky outcrop, which is not the time to find that your legs don't work or you suddenly go dizzy just as you disconnect from the helicopter and it flies off. So it is, to me, it's kind of a common occurrence. You just don't hear about it.
Yeah, there's not that much in the literature these days. One of the best papers was published in the 2011 Wilderness and Environmental Medicine Journal, which gives a comprehensive overview of it, the terminology, pathophysiology, etc. But essentially, when somebody is suspended vertically in a harness for a prolonged period of time with limited or no movement of the lower extremities, suspension syndrome can occur, not necessarily trauma. Interestingly, some studies have shown that this can occur, unconsciousness can occur, and death can occur in less than 10 minutes. And some studies have also shown that it's more common with chest harnesses, potentially due to the increased pressure around the thoracic cavity, potentially reducing respirations. But the evidence is varied. Factors that contribute to it: anything that's going to affect your circulatory status. So hypovolemia, vasodilation, dehydration, cardiac issues can compound or contribute to this syndrome. Pathophysiology chain of events, really what's happening? At a simple level, because the lower extremities are not moving and there's restriction of the proximal part of the lower extremities, blood begins to pool in the lower extremities. There's a lack of blood flow in the venous system back to the heart, a lack of preload, relative hypovolemia, which ultimately reduces the afterload, the systolic blood pressure, which can reduce cerebral perfusion and lead to unconsciousness, and then, due to the position, can obstruct the airway with the tongue and lead to death very, very quickly. There's mention in some of the literature that the lack of preload can generate basal-gyrus reflex or bradycardia to try and fill the chamber and increase the ejection fraction. So you might see bradycardia, which is not common in shock, rather than tachycardia. So essentially we've got up to 60% of the blood pooling in the lower extremities, not reaching the heart and not being circulated, leading to reduced cerebral perfusion, potentially altered mental states, unconsciousness, airway obstruction and death, potentially very, very quickly. So what do? Anybody trapped in a vertical position in a harness should try and cascade the following as quickly as possible. Number one, as we always do, communicate our situation as soon as possible, whether it be shouting down to a teammate, communicating on the radio, the satellite phone. Let somebody know that you're trapped, because very, very soon you could become unconscious. Number two, where possible, where technically feasible, try and self-rescue, try and free yourself from the harness. Get down, use prussics, ascend, descend, however you can, but get out of that position. If you can't, if it's not possible to self-rescue, then try and raise your lower extremities, if you can, through prussics or slings, or placing your feet against the rock face and climbing up so they're in a horizontal position. And then contract the muscles. Keep moving the legs, keep contracting, wiggle the toes, contract the calves to try and stimulate some blood flow and push it back into the central circulation. So anything, if you raise the legs, contract the feet, do what soldiers do on the parade ground so they don't faint, keep wiggling the toes and contracting the calves just to shunt that blood a little bit higher.
And also from like the rescue point of view, like the short haul, I had one of the new guys, he came with a pet bag and I did the quick strap. He had his thigh straps done up really tight, whereas I had mine really loose. So once you're lifted, I was able to kind of wiggle my backside backwards so that I was sat rather than hanging, whereas he did the opposite because he's dangling under a helicopter. He did them really tight, and not only did he have a bit of pain, he's potentially put himself in a situation. And also for rescuing, similar to some of the things you mentioned, there was a paper 2011 in aviation, space and environmental medicine, and that's respiratory function in hoist rescue, comparing sling, stretcher and rescue baskets. It's a kind of an interesting read. There has been a lot of studies, especially on hoist work, putting patients in slings, their effects on the respiratory system, preload, afterload, all that kind of stuff. So there is a couple of papers out there. If you know about it, you can prevent it, or at least be thinking about it. If that's your rescue plan, is to put somebody in a harness, these are the considerations that you'd have to go through, that kind of thing.
And as we do, have a plan in mind, dry test it, talk it through, rehearse it in a sterile, controlled environment. If your plan is to raise your legs using prussics or slings, practice it. Don't rely on skills that you haven't tested in a long, long time. So yeah, practice it. Check your communications, check your harnesses, check your equipment. And then if you're unable to prevent it, you're unable to self-rescue and you find yourself trapped, keep moving. If you can't keep moving, you become unconscious. What can rescuers do? What can we do as paramedics, EMTs, rescue techs? The old literature used to suggest lower the patient down in a seating position, maintain them in the seating position for up to 15 minutes and gradually lower them down to the supine position. That's changed. The latest evidence simply says rescue as quickly as possible, and as quickly as possible despite the pooling blood and the build-up of waste products in the lower extremities. Release the harness and place the patient in the supine position and continue normal resuscitation efforts, simply because the most important things are free them from the risk, restore cerebral circulation, and manage the airway. Without doing those things, if we maintain the unconscious person in the seated position for however long, 5, 10, 15 minutes, they're going to have reduced cerebral perfusion. We're still going to have difficulty managing the airway. So 3-step process. Rescue and lower as quickly as possible, place in the supine position, and then manage your ABCs as you would for any other resuscitation. Keep it simple.
Yeah. Is there because some of the papers used to treat it similar to a crush injury, didn't they?
It's interesting you mentioned that there's talk of, in some of the papers, mentioning treat as a crush injury, fluid resuscitation, sodium bicarbonate, etc. We really, on this podcast, want to emphasise what the literature is emphasising these days. Rapid rescue, supine position, return or restore the cerebral perfusion, manage the airway, and then manage the resuscitative efforts as you would with any other patient in shock. So you may need to give them boluses of saline solution, you may need to manage the airway, but at this stage, that's where we're going to focus. Anything beyond that is beyond the scope of this discussion, but there is a possibility of the development of rhabdomyolysis from prolonged entrapment. So irrespective of the initial or medium-term outcome of the patient, anybody entrapped for a prolonged period of time should be sent to definitive care for further assessment of potential rhabdomyolysis.
If you have the skills to rescue them in the first place.
Yeah, absolutely. Do you have the skills? Do you have the equipment? But I think the most important thing is keep it simple. Can you get to them? Can you safely get them down? Remove the harness, increase the blood flow, improve the preload, improve the systolic blood pressure, whether that requires boluses of fluid, and then manage the airway and any other standard resuscitation efforts that are needed. That's kind of what is resounding in the literature at the moment.
Awesome.
Fantastic.
A lot simpler than people make out.
And that's why we wanted to highlight it. It's people often try and avoid talking about it because they get confused and overcomplicated. It could happen. You need to plan to avoid it, and you need to be able to recognise and rescue quickly if it does occur. So, nice short podcast.
One of the first short podcasts.
Powered by lots of coffee. So, what does the future hold for us? Hopefully we're going to do another couple of podcasts next week. We've got a British Army lad on attachment from the Royal Army Medical Corps. He's on attachment with SOS Medical Services in Guatemala. Hopefully he's going to do some ground and air critical transport, some standard frontline ambulance attachments as well. But he's injected a bit of motivation into the team as well. We'll give a report on that, get him involved in a podcast next week. But we've got lots of other stuff coming up. We're going to be heading down to Argentina, Ecuador, Mexico and Peru in the next 3 months, teaching wilderness first aid and the Red Med course. So no doubt there'll be podcasts coming out there and reports and stuff on the social media all over. It's going to be absolutely fantastic, with a bit of tactical medicine thrown in with the Colombian Army. So yeah, interesting couple of months coming up. If you want to come on the podcast as a guest, or you've got some topics you'd like us to talk about, please get in touch with us. You can find us, the podcast, on iTunes or Spreaker under Red Med Podcast. You can find us on Facebook at SOS Med Training, or at Red Med Men, or Rescue Expedition in Disaster Medicine. You can also check out the websites, which are redmed.education or soserviciosmedicos.com, or in the other language, serviciosmedicosos.com. There, please leave your comments. Anything you want to talk about, we'll more than happily bring it up in the future posts.
Excellent. We're going to go debrief a flight.
Fantastic. Yeah, this morning we had an interesting flight. We ended up doing ultrasound at the side of the road, doing a fast scan, testing for cardiac tamponade, ICP. First time we've deployed that equipment in this service, and it worked absolutely fantastically, as did the ketamine.
Yes.
That's a whole new podcast. Okay, guys, stay safe, and we'll speak to you soon.